Start. Welcome to AETCM, the Emergency Medicine Channel. Today we are going to discuss about an elderly female who came to our ER with complaints of fever and tiredness. So shall we start? A 60-year-old female presented to ER. Initial 10-second assessments. The patient is conscious, oriented, normal breathing pattern and normal pallor, no pallor. So right now starting with primary survey, patient airway, no any patent airway, sir. Breathing wise, respirate rate was 20 per minute and saturation 97% at room air. Regarding the circulation, BP was 130 by 70 and pulse was 74 per minute, sir. And regarding disability, GCS was full E4, V5, M6 and pupil dilated and reactive to light.
What is ABPU score?
ABPU score is for pediatric assessment, same like primary assessment. There we use the alertness, breathing.
Instead of GCS?
GC.
ECS one.
Yes. And next coming to the exposure part, the patient right now has a temperature of 101 degree Fahrenheit. So at this point of time, 1 gram PCM injection was given to the patient. Coming to the...
What are the real indications for paracetamol IV?
Unresolving fever.
Paracetamol tablet is more. Febrile seizures. Cardiac failure, stroke patients, pregnancy. So the 4 major indications for immediate relief of fever by paracetamol. Other conditions you can give. I'm telling they are the absolute indicators.
Like coming to the adjuvants to the primary service, in the VBG was showing no acid-base balance disorder and all electrolytes are normal, sir. Coming to the point of care, CBC point of care, CRP was 121 with granulocyte percentage of 78.2% and counts 13.6. So coming to the secondary survey, patient is a known case of type 2 DM, hypertension, CAD, sir. And she was on her own medications for regarding the same. Patient had fever with chills of 3 days, associated with left flank pain and 1 episode of vomiting. In view of the fever and chills for last 3 days, when she visited the outside hospital, the counts were elevated and because she was having left flank pain, they did an ultrasound, which was showing features of pyelonephritis. Associated along with that, she was even having burning micturition also, sir. And she was started on initial oral antibiotic from the outside hospital, but consecutively she developed weakness and malaise, and she was not even able to get up from the food, reduced food intake, and so that's the reason she was brought to our ER. And regarding the
common reasons for weakness like this in a patient with UTI,
because of dehydration.
Dehydration is one of the most important.
And also because of the sepsis component.
Sepsis.
Higher metabolic activity and...
Sepsis with high metabolic activity. You might have seen so many urinary tract infections here, elderly individuals. Yes. What is the common cause for weakness in them? Hyponatremia is the most common cause. As such, fever and UTI itself can produce weakness. But hyponatremia in most of these patients can develop hyponatremia, and that will produce excessive weakness in them. Okay.
Apart from that, regarding the past history of the patient, 3 weeks ago she was admitted in a hospital for the same of UTI, sir. At the time, just for a UTI, she was admitted, she was given IV medications and discharged after 3 days. So, and regarding the examination part, general examination is all normal. In the abdomen part, there is tenderness in the left loin region. So I continued with the investigations, the initial lab showed procal of only 0.30 and then CRP of 192, sir, and counts are 14.8.
What are the reasons of low procalcitonin in patients who is having infection like this?
Sir, actually outside already oral antibiotic was given, so
already treated, procalcitonin will come down.
Other
localized infection, minimal procalcitonin elevation can occur. Third one?
False.
Third one is positive. But if it is viral UTI, that is one of the common cause we are seeing every day. Most of the cultures are negative in UTI. That is only viral UTI. Okay.
So in this case, as regarding approach to the treatment of the UTI, we can divide it either it's like an acute simple cystitis or it's an acute complicated UTI in view of the treatment. Otherwise, normally we classify as a normal UTI or complicated UTI. Complicated UTI being the sense that some urinary obstructive tract obstruction was there because of that, or in diabetes patients some comorbidities is there.
Stone structure, malignancy, BPH, and diabetes. All these things are considered as
Complicated UTI.
Okay. Complicated UTI doesn't mean that complication occurring due to urinary tract. It is because of some complication, high risk patient developing UTI. Okay, including malignancy, immunocompromisation, everything come under complicated UTI.
And regarding the microbiology part, E. coli is the most common organism, and there are specific organisms, like if it's a hospitalized patient, previously hospitalized patient, it can be a Pseudomonas, or if it is in a young person, it
what
can
are
be...
the histories you take from the patient other than hospitalization? Histories, previous histories.
Previous history, sir, if she is on any medications.
What medication?
Dapagliflozin. Higher risk.
Dapagliflozin. That produces sometimes UTI. Okay. What else? Very important thing.
Like depending on male or female.
Previous culture. That is very previous catheterization. That is very important. Unsterile catheterization is one of the cause for UTI. Okay. So catheterization history you have to take. Any injuries during catheterization, that you have to take. Then male previous cultures. That is also very important. What is the importance of previous cultures?
If an isolate is found previously of the certain species resistant to certain antibiotic, there is no point of like.
So repeatedly you are getting same organism in all the cultures, or few cultures you are getting same organism. Then the problem is that UTI is not completely treated. Recurrently the same organism is coming out. Okay. So we have to be very careful in that conditions. If all cultures are different organism, then it is an external focus, or from externally it is spreading inside. So that can be treated fast.
And if suppose if it's in an young adult, we can suspect Staphylococcus saprophytic.
Young adult, male adult coming with UTI, what is your first suspicion?
It's because of sexually transmitted.
Sexual. You have to take a sexual history, or suppose he doesn't give, you have to rule out that type of organism and you can treat accordingly.
Like a differential diagnosis, if it's a cystitis, differential diagnosis of cystitis is urethritis, interstitial cystitis, then vaginitis, and BPH can also cause, and also bacterial prostatitis most commonly will be associated with cystitis in men. Okay. If it is a pyelonephritis, differential diagnosis, we have to see if it's a nephrolithiasis. Nephrolithiasis indirectly can cause obstruction and lead to infection itself, or if it is any renal infarct. In renal infarct, the other thing...
Nephrolithiasis, which is a common cause in our country?
Calcium.
Urea. Very rarely you get. TB. TB will not produce nephrolithiasis. Uric acid. That is the most common condition which is seen in our practice. Okay.
Next, even herpes zoster, if it's involving lower dermatomes, there can be vesicles and a flank kind of pain mimicking pyelonephritis.
Okay.
Other than that, sir, regarding imaging, ideally we can wait on imaging starting with an empirical antibiotic and seeing if it's worsening after 48 hours, then definitely we can go with an imaging. Or if you're suspecting any anatomical obstructing kind of a feature, then immediately.
What imaging you want to do?
Gold standard is the CT plane.
Normal test first.
First, no, ultrasound.
X-ray. X-ray will pick up most of the stones. Okay, not all, but radiopaque stones can be picked up.
Initial test.
Then
we can
ultrasound. Ultrasound, what do you see?
HUN, or if there is any fat stranding around the kidney, suspicion of anatomical obstructions can be
picked up, and you can see the hydronephrosis. Like that, you can see prostate can be seen. Post-voidal residual urine can be assessed. Okay, all this, and so a lot of like echogenicity in the bladder can be assessed. Okay.
And the gold standard is the CT. In CT, in case of pyelonephritis, we see localized hypodense kind of masses in the kidney, depending upon the location. Regarding treatment, as in this case of the patient, we have
urine culture. Didn't tell anything.
Yes, sir. We need to send the urine culture, and before that, we
need. How do you take urine culture? Midstream sample you have to take. Okay.
The pyuria is usually associated with the UTI, but it's not indicative of
indicative of
UTI,
infection.
infection.
Okay, it can be seen in non-infectious cause also, especially in female patients without any infection. You can get epithelial cells; they will be misdiagnosed as UTI. Okay, so female patient, a large number of pus doesn't mean that she's having UTI. Okay.
And
What are
next,
the other conditions where you get culture negative pus cells? Culture negative pyuria.
TB
TB is
major.
one of the common causes. Then fungus, virus, partially treated UTI. So all these things you have to rule out.
Next, we divide treatment empirically we start the antibiotics, that we divide the treatment depending if the patient is critically ill or there is a component of sepsis going on, multiple organs involved. In such cases, we start with empiric regimen including an anti-pseudomonal carbamazepine plus vancomycin. Apart from that, we consider if the patient is in a high prevalence of ESBL. In case of high prevalence of ESBL organism, then we start with anti-pseudomonal carbamazepine plus vancomycin. If it is low ESBL, then we can start with other normal hospitalized medication. If a patient is hospitalized, like IP patients, we consider whether the patient, we are suspecting a patient to be an MDR or not. Conditions to consider whether the patient is MDR or not by taking a history of the last previous 3 months. If he had taken any use of fluoroquinolone and fluoroquinolone or trimethoprim sulfamethoxone, or if there is any isolate showing that it is resistant to fluoroquinolone, or patient is hospitalized for any condition within the last 3 months. In view of this, we will consider patient is a high risk of MDR, and in such cases we should start with piperacillin tazobactam as the initial line of drug. If it is a low ESBL kind of prevalence area, then cefepime is enough, sir.
Prevalence area?
In India, as it's our India, it's high prevalence, it is our ESBL.
It's very difficult to tell that this is high prevalence, this is low prevalence. So that is difficult.
If there is no risk of any MDR kind of a case, then we can start with ceftriaxone 1 gram. And alternatively, if ceftriaxone is not warranted, then we can alternatively use fluoroquinolones like ciprofloxacin or levofloxacin, sir.
Okay.
But if ideally, if we have any culture isolates in previous admission or previously known anything with that specification also, we can avoid whichever is resistant, we can change the antibiotic. If it's an patient is completely stable and we can treat with oral medication, then we can start with ciprofloxacin as the empirical management. Okay. Ideally, any antibiotic as empirically we start, we need to send for a urine culture, and once the culture comes, we need to taper the management as per the culture.
Okay. What are the drugs which can prevent urinary tract? Because if you treat a complicated UTI, you can see recurrently patient develop UTI and they'll come back again and again. Yes. So how do you prevent UTIs?
Initially, basic management would be changing the pH of the urine.
pH?
I mean, if it's a acidic kind
you want to make it alkaline. Acidic is due to the bacteria.
Yes, sir. So we want to make it
alkaline. If we make it alkaline, bacteria will not die. I am asking about prophylaxis.
Prophylaxis, we can give nitrofurantoin as
nitrofurantoin can be given.
Phosphomycin in complicated
even quinolones, Norflox prophylaxis can be given. All these things can be given. What is this phosphomycin? How do it which all conditions you give? How do you give?
If it is an MDR recurrent UTI with MDR organism suspected, then ideally we go opt for phosphomycin sachets to be given 3 times. I mean, 1 sachet every 3rd day for first 3 times, and then once for every 6 weeks.
Some patients require only 1 dose. Most of the patients with a simple UTI may require only 1 dose. Some patients with complications, you can give like 1 or 2, 3 doses. And every week you have to give prophylactic doses. Okay, so that also can be given. What is? Can you tell about ertapenem usage in urinary tract infection?
There is a comparing ertapenem and meropenem, there is higher percentage of ertapenem as a drug found in the urinary tract, so it is preferred rather than meropenem in UTI.
Where it is not useful?
In sepsis.
So if the patient is having septicemia, then ertapenem is not a good choice. It will not act in the blood. But if you, like you told, if it is only a urinary tract infection, the concentration of ertapenem is very high in the urinary tract, and that can be given. Okay. But if the patient like this, sepsis patient has developed sepsis, then this is not a good choice. Advantage of ertapenem other than this OD dose can be given. and you can patient can be discharged with that. Once daily they have to come to clinic and take it. Okay. What suppose this patient? This is a female patient.
Yes,
Suppose this patient is having a prostatomegaly. How do you manage?
female.
No, not this patient.
Male patient.
Male
Yes, sir.
patient. Sorry.
Prostatomegaly, we need to identify the size and we need to give him alpha blockers so that it can, BPH must be
Okay,
released.
you have to see what is
Avoid the collection of the urine.
Okay, you have to see what is the size of the prostate. You have to start alpha blockers and try to reduce the size. What about PSA during acute infection?
PSA is falsely elevated
It can be elevated in any prostatitis, so better not to do PSA in the first week or second week. Then once the patient recovers from the acute infection, you can probably do the PSA and find out what is the range. Okay, so that should be done. In prostatic malignancies, what are the other investigations you do other than PSA?
MRI, prostate.
MRI, prostate can be done. Okay, then other areas you can pick up, means prostatic
Bone cancer.
bone
Metastasis is
metastasis. Calcium will be high.
Higher.
Alkaline phosphatase will be will high or low?
High.
It has to be high.
High.
Tell me one condition where the alkaline phosphatase is low in bone multiple myeloma. So except multiple myeloma, all bony lesions you can get very high. Okay. Now suppose the patient is having high uric acid, urinary stones. How do you manage?
We need to start with removing of the uric acid by using febuxostat.
Febuxostat can be. What is flush therapy?
Sir?
Flush therapy. So even without prostatomegaly, in a patient who is having stones with urinary tract infection, to relieve the edema and symptoms of this one, you can give flush therapy by starting alpha blockers. Okay, that is not started for your prostate. It is started for something else. It is called as flush therapy. Okay, so that also can be tried. How is this patient now?
As of now, a patient was started on empirical antibiotics and the infective counts are downtrending, waiting for the urine cultures.
Okay, sodium is normal?
Yes, sir, 135, sir.
135. What is the reason for hypernatremia in urinary tract infection?
Initially, because of more amount of
urinary loss. Yeah, it resembles like SIADH.
Yes.
You see this type of patients in ER, it will resemble just like SIADH. Low sodium in the blood, high sodium in
urinary
the urine, and high osmolality in the urine. So you should not misdiagnose it as SIADH. Okay, there is no need to start tolvaptan. Okay, it's only because of the breakage in the epithelium. Okay, female patients UTI, anything else can be done? Old female patient, what? Huh? Organ prolapse, this structural cause should be ruled out, and the estrogen creams can be given because that is one of the major cause for epithelial shedding into the urine. That will be misdiagnosed as UTI, and they can have UTI also. So better to give some local estrogen creams to prevent that. Okay. Anything else you want to add?
No, sir.
Anything else? Nothing. Okay. Thank you.
Thanks.